what are the signs of liver failure? So if a patient comes, when you say failure, that means it gives you a feeling that there is some decompensation which is happening, or the liver has actually failed. So when you say an acute liver failure, when the patient is having bleeding in the form of coagulopathy and encephalopathy. So coagulopathy and encephalopathy are the hallmark of acute liver failure. Otherwise, if you do a head-to-toe examination, what are the different things which you have to look for? These are the things. That is, first you have effect of portal hypertension in the form of esophageal varices, ascites, and splenomegaly. So those are the predominant features. Then liver cell failure, you have icterus, just from head to above. First thing is hepatic encephalopathy. When you go from head to above, hepatic encephalopathy, which manifests as asterixis or flapping tremor. Similarly, in a patient with hepatic encephalopathy, you have something called fetor hepatitis, that is a sweet ammoniacal odor, which is seen in patients with hepatic encephalopathy. So what do you mean by encephalopathy? That is when the patient has certain complications of portal hypertension. So portal hypertension results in HE, that's hepatic encephalopathy. The commonest causes we'll be learning in the rest of the classes when we learn in detail about cirrhosis. Then spider nevi. You can see the spider nevi anywhere in the torso, upper part of the body, the arms, and the neck. Scleral icterus, what we already know. Then gynecomastia, parotid enlargement, testicular atrophy, and loss of the male type of hair distribution. So this is characteristic of hyperestrogenism, and that is seen in patients with alcoholic liver disease. Then you have the flapping tremor seen in the hands. In the eyes, you have to look for KF ring, which is seen in patients with Wilson's disease. Skin changes. Apart from this, you have also several skin changes in liver patients. One is itch marks because of pruritus. Then you have xanthomas or xanthilesmas, which are seen in patients with primary biliary cholangitis. Earlier, it was called primary biliary cirrhosis. Now it's called primary biliary cholangitis. And you have mucocutaneous vasculitis with purpura. So mucocutaneous vasculitis with purpura. This is usually seen in patients with cryoglobulinemia or hepatitis B and C. C more common than hepatitis B. Okay, so these are the skin manifestations. Apart from this, you have a slate gray pigmentation also, which is seen in patients with hereditary hemochromatosis. Then apart from this, you have bleeding tendencies, that is itch, and you can see the bruises. What can you see in the abdomen? Now, what are the features of advanced liver cell failure? Okay, features of advanced liver failure. One is muscle wasting. So severe ascites, then sarcopenia or muscle wasting. This means the patient has ascites with edema also. Ascites will be associated usually with edema. Muscle wasting or sarcopenia is present in advanced liver failure. Icterus or jaundice. This is a feature of advanced liver failure. The presence of caput medusae. The presence of dilated umbilical veins. That is your caput medusae. Okay, so these are some of the features of liver cell failure. Similarly, flapping tremor or asterixis, fetal hepatitis. So if any of this is present, which means the patient has features of decompensation. Okay. So when you broadly classify, this is what we need to know before we get into the approach to a patient with liver involvement. Okay. What are the other things which we need to know is the history of the patient. Okay, when you approach a patient with abnormal LFT, how important is the history of the patient? So history, when you think of history, you should know what are the causes of liver involvement. So it can either be acute causes or it can also be chronic causes. Fine. So acute causes are usually your infectious causes. It can either be typhoid, it could be malaria, dengue, enteric fever, that's what. So these are the leptospirosis, scrub, Q fever, brucellosis. All of these are usually infectious causes. Then chronic causes. Chronic causes, the most common would be alcohol intake. So whenever you ask a patient with jaundice also, you have to always ask the history of ethanol intake. That is permissible is always only 11 to 15 grams. So if a woman takes more than 3 drinks, or man takes again more than 2 drinks per day, then it is considered again as injurious to the liver. And most of the patients who end up in alcoholic liver disease, they would have taken it for more than 10 years. Yeah, Nail changes are also there, Himanshu. Yes, nail changes are definitely there. Especially nail changes. One is hypoproteinemia you have to look for. Second is you have the blue lunules, which are also seen in patients with Wilson's disease. Plus pallor. Pallor you look for. Clubbing is important because clubbing you're looking for in a patient who is prone to go into HCC, one thing malignancy. Second is you have a hepatopulmonary syndrome. Okay, and a cirrhotic cardiomyopathy. So any of these complications develop. There you have them. Nail changes are very important. Otherwise, pallor of the nails is important. Hypoproteinemia and blue lunules are also very relevant. So one is alcohol intake. Second is the presence of non-alcoholic fatty liver. So now the term is not non-alcoholic fatty liver. The term is now metabolic dysfunction associated steatotic liver disease. It's called MASLD. So when you finish alcohol, next is non-alcoholic or MASLD, metabolic dysfunction associated steatotic liver disease, which means what? They fit into what is your metabolic syndrome. So which is your metabolic syndrome? You know, diabetes, you have HbA1c above how much, hypertension, hypertriglyceridemia, and the abdominal circumference. So taking all this into consideration, if a patient also has an enlarged liver or altered echoes of the liver, an abnormal LFT, then you have to think of non-alcoholic fatty liver or MASLD, which is the cause for liver involvement. Third is important history is travel history. Travel history is also very relevant, especially to endemic areas where hepatitis B is important, being present. Travel and immunization. Presence of tattooing in the body or body piercing. Any part of the body which is being pierced. Then sexual history of the patient is also very important, especially if they have multiple sexual partners, men who have sex with men. Mother to child transmission, if any family history is present, especially in the mother, because in our country, mother to child transmission is the most common cause. That's a perinatal transmission is the most common cause for hepatitis B. Whereas for hepatitis C, and even sexual cause is also there. Hepatitis C, it's usually because of IV drug abuse. Okay. Then even another one is blood transfusion. The presence of history of blood transfusion or any blood products. So this is relevant if it is before 1986, because before that you never had core antibody which was checked for hepatitis B, okay, and 1992 for hepatitis C. So any history of blood transfusion or blood products before these years is what is important, because after that, most of them, they have been screened well. So these are the common history which you have to know. Apart from this, you also have to know congenital causes. If any congenital cause is there in the family, especially you have intrahepatic cholestasis, that runs in family. Then you have Wilson's disease, especially if it's a young male less than 40 years. According to Schlesinger, what they say is Wilson's disease can present anywhere between 3 and 55 years. So any young child with neuropsychiatric manifestations, always rule out a Wilson's disease. Not only young child, any childhood to adulthood up to age of 55, you can make a diagnosis of Wilson's disease. Similarly, Alagille syndrome. Alagille syndrome also can result in cholestasis, and it can result, it's a form of congenital or something which is a hereditary cause, you can say. Okay, so this is important when you're looking at history of the patient. Okay.